Hello everybody, I would like to welcome you to the update Geriatric Anesthesia with the topic Impact of Premedication on Elderly Patients' Outcome. We consider and talk about outcome. It's of course many different items need to be addressed. It's not just the typical outcomes such as post-operative nausea and vomiting or pain or post-operative delirium or generally feeling well. But we need to consider that all these outcomes are to some extent connected with one another. So it makes sense, obviously, to evaluate all these items separately to see that one does not go and influence the other by over treating pain, for example. Then you produce additional nausea and vomiting, or by treating stress and anxiety, you are producing post-operative delirium or sedating the patient. So they are to some extent interdependent, which makes it necessary that all single items of these so-called patient-reported outcomes or post-operative neurocognitive disorders are addressed in one matter and are also visualized in one display. And in order to achieve a maximum of positive outcomes, especially in geriatric patients, of course, it's important that we remember that it's a multifactorial approach. There's not just one single bullet solution in order to achieve superior outcomes in regard to all aspects of outcome, but we need to address these items to some extent topic-wise. So it requires a multifactorial approach. So how can we best address the stress and anxiety issue in the perioperative context? And this is a to some extent neglected topic. And there are some points that are extremely important, and this is from my perspective and also maybe more generally speaking important in regard to especially the induction part of anesthesia, where we have to establish a safe surgery checklist. And by giving early on premedication, especially in elderly patients, already on board in order to attenuate the autonomous nervous system, or specifically stress and anxiety beforehand, you take away the option of performing the safe surgery checklist prior to induction of anesthesia. This is one problem that needs to be considered. Another problem, which is extremely important from the patient's outcome side, is that of course we should establish a cognitive baseline for the patient before we start anesthesia, because it's obviously our job as anesthesiologists to make sure that this patient that receives anesthesia, and of course we are guiding through the perioperative process, that we know how was the patient before surgery, so we can establish also afterwards that we know this patient is in the same cerebral status, cognitive status afterwards as the patient was before. And by giving benzodiazepines early on ward, we take not only the safe surgery checklist, but also the option of making sure that this patient is not has not been affected by the without us recognizing, has not been affected by anesthesia and surgery as he should not have been. So important from our perspective, the first rule of the Safe Brain Initiative is that we aim for all patients, when they latest at discharge from the recovery room, that they should be again in the same situation cerebrally from their cognitive status that they were prior to surgery and anesthesia. So the baseline needs to be maintained or needs to be reached latest after the patient is ready for discharge from the recovery room. And this is extremely important because we know that especially post-operative delirium, as kind of the peak of the iceberg, is the most common post-surgical complication, with incidences up to 50% in elderly patients, depending on in which setting you see. And all associated outcomes can be affected by post-operative delirium: length of stay in the hospital, additional problems, long-term cognitive dysfunction, but also increases in mortality. And most importantly, for our perspective, is that we need to keep in mind that about 40% of patients can actually be avoided, that the patients develop delirium. So it is the bundle of measures that we address that is important here. Another problem is, and this is a more recent publication published in 2019 in Lancet, is that about 7% of our patients perioperatively develop what is called a perioperative covert stroke, meaning that patients older than 65 in the perioperative process, this is about a time window of 7 days confirmed by MRI, in this multi-center, very fine multi-center study, that 7% of our basically bread and butter kind of patient collective had a visible covert stroke in the MRI. And this is, of course, a kind of a dramatic outcome. And of course, it doesn't mean that all of these strokes occurred intraoperatively, but chances are fairly high that a larger amount has occurred intraoperatively. So it's our job, or it should be our job, to have a patient as much in a cerebral status afterwards that we are able to compare before and after to see if we have been causative involved by generating too much hypotension or not taking care of hypotension or any other relevant measures that are changeable. So which medication candidates are promising? Dexmedetomidine was certainly one of the promising candidates because of its very fine characteristics. It's not primary GABAergic. It doesn't primarily bind on the GABAergic receptors. It is known for its very fine feature that it simulates the normal, or is very close to simulating the normal sleep architecture, thereby not being as involved in inducing or in being a risk factor for postoperative delirium. Problem for Dex is that it has a long onset time, and in this study, very fine study from Behrens and colleagues, senior authors, the anti-epsilon, they performed this randomized controlled study and looked at patients elder than 65 in regard to the nasal application of, as a pre-medication, nasal application of dexmedetomidine. And what they found out, that would have been a very fine solution, but what they found out that in the majority of these patients, blood pressure side effects occurred with decreases in systolic, but also in MAP pressure, more than 30% in some of these patients. This, of course, an unacceptable high number as a side effect, actually to some extent counterproductive in what it actually tried to achieve. And this was, interestingly enough, independent in regard to if the patient were on antihypertensive medications or not, especially benzodiazepines. So there was no increase in hypotension if benzodiazepines were used or not. So this was not the influencing factor, but nevertheless, extremely fine performed study, but unfortunately not really helpful for answering the question which medication is best suited for attenuating this kind of ANS reaction preoperatively or perioperatively. Another highly interesting candidate is Remimazolam, which is quite willingly similar to remifentanil by choosing this name. And this is a benzodiazepine which was approved in the US in July 2020, in the European Union in March 2021. And it's used for induction of anesthesia and conscious sedation for minor invasive procedures, as it was stated. And it has the very interesting feature, if you look at the graphic up there, that you can see that there's an ester connection there. So it is metabolized, not over the P450 cytochrome, as most of the GABAergic substances are. It's a ester hydrolysis, so it's by the free tissue esterases actually metabolized similar to remifentanil. So it has a much better pharmacologic kinetic and elimination half-time than the usual benzodiazepines. So when you look at the peak effect size concentration also and compare this to the time until it reached the peak after you gave a bolus of this medication, you can see this is quite an acceptable time, between 1 to 3 minutes. The peak is received. So you know that even when you use it short before induction of anesthesia, after you have a safe surgery protocol with your patient, or went through the safe surgery protocol with your patient, you still have enough time to give this medication without causing too much delay in the anesthesia procedure. When you compare it to midazolam, which takes up to 5 minutes, and I'm not even talking about dexmedetomidine, where easily 30 minutes, you need to have 30 minutes of time before in order to achieve the same effect. Also interesting, the context-sensitive half-time in application of Remimazolam is that it doesn't matter, even if you give repetitive dosages, that after 16 minutes, due to these tissue esterases, you know that Remimazolam is eliminated from the system. So again, easy to use as at the induction time or before induction time because of the short reaction time, and due to the elimination, you can be fairly certain that even in short surgical procedures, the outcome and the evaluation of your patient in the recovery room in regard to the cognitive status will be not affected, or at least possible affected by this potential anxiolytic stress-reducing agent preoperative. So in short, compared to midazolam, has a more rapid onset, 1 to 3 minutes, a shorter duration, 7 to 8 minutes, no active metabolites, again in the free esterase in the tissue metabolize it, and thereby faster recovery times and absolute predictable and consistent pharmacokinetics, which make it uniquely compared to midazolam or also dexmedetomidine suited for this prior to induction, after identification and a safe check-in procedure of the patient to be administered potentially, and again without compromising the evaluation, the cerebral or cognitive evaluation of your patient in the post-operative setting. Up to 6 hours in midazolam, as we know. And obviously, this needs to be further examined, but seems to be one of the very interesting options that down the road might be an interesting substance for us. Thank you very much for your time, and if you have any questions, please feel free to address me over this address or also directly. Thank you very much.